Hello, everyone, and welcome back to class. This is our first screencast for week number 4. And this week, we are heading into different study designs. And so exploring some of the main study designs in a little greater depth in order to help you formulate and develop your research study for this class. Now, again, remember when I say research study, you're coming up with an idea. You're going to present an introduction, like I mentioned before. What's the background? What is the purpose of the study? Why is the study needed? You'll discuss the methodology and you'll discuss the statistics used. This week, we'll also present some of the statistical analyses so you have an understanding what to use and when. And we'll do a little bit more with that next week. There's a homework assignment for this week, and also there is a discussion topic. Now, the dates on this one here are incorrect. The correct ones are in the week 4 module on the platform. So risk, that's the probability of some untoward event. In healthcare, we're obviously dealing with probabilities. When you think about a surgeon making a decision, is it appropriate to do a surgery, or am I exposing the person to more potential harm? Right? I think an obvious situation is an individual with cancer who is at such a stage where there's likely no chance of the surgery being successful, or exposure to the radiation, chemotherapy, having any success, except for maybe prolonging life another 3 or 6 months, but the person is going to be suffering a lot in response to the surgery or in response to the chemotherapy. So that's a potential risk. What could be another risk? Not doing something, or choosing between one medication versus a different medication. So looking at these potential probabilities, because again, sometimes things are very beneficial and there's little to no risk. Other times we've got to weigh the risk and make sure that we're making the best decision with our patients. So when understanding risk, what we're doing is we are observing the relationship between exposure to possible risk factors and subsequent incidence of disease, or, like I said before with the cancer example, what is the risk of X, Y, or Z if the surgery occurs? Or what is the risk to the patient if the surgery isn't performed? So somebody can have potentially a disease and you're looking for the risk of recurrence. Now, the prospective study is the gold standard. It's the most powerful way to determine whether the exposure to a potential risk factor results in that increased risk of the disease or the injury or the outcome of interest. So you've got one group that's exposed to a purported risk factor, or one group that maybe has the risk factor, and the other group doesn't have the risk factor. Now, not all prospective cohort studies are able to be conducted or performed. There are times when an experiment is not possible or ethical. So we can't do prospectively some of these studies because of ethical reasons. For example, let's say you have an experimental group gain a lot of weight on purpose to increase their BMI above 30, and then they are asked to maintain that weight over time to observe for incidence of cardiovascular disease. And then you could compare them to another group that doesn't have a BMI above 30. Or we wouldn't require an experimental group to initiate a smoking habit, right? And, I think if we look at what the smoking research was all about, those were oftentimes case control studies early on that determined that smoking put people at a greater risk. So what would they do with like a vaping study or like a marijuana study? Marijuana being legal in the majority of the states now, you probably wouldn't want somebody to initiate purposefully a smoking habit with marijuana for the purposes of seeing if they go on to develop a disease later on. You also wouldn't want to require an experimental group to purposefully perform risky driving behaviors like, hey, you've got to do 10 texts every time you drive to work in the morning versus a group that doesn't have access to texting on their phone. It is unethical to impose possible risk factors on a population of healthy people. Many people would be against having their behaviors or diets drastically changed, and so even if you were able to pull that off, many people would not participate after a period of time, and you would have a lot of dropouts. And the study types described on the prior slide would need to be conducted for years. This would be costly and time intensive. And I've given the example of the Framingham study many times. This is where you would need to have a large machine in place, a lot of money, a lot of people to be able to do something very, very big at that level. So let's talk about observational studies, prospective cohort studies being one of those. And again, we touched upon this in week 2. Observational studies are ones in which researchers gather data through observation, but they do not intervene. Remember that person running backwards on the treadmill. You may think it's going to put them at a greater risk, but you don't intervene. You just wait and see what happens. Now, most studies of risk are either cohort studies or case control. Cohorts are a group of people who have something in common when first assembled and who are observed for a period of time. Observations of a cohort should fulfill 3 criteria. They do not have the disease or outcome in question at time they are assembled. They should be observed over a meaningful period of time. So what's an example of this? You wouldn't have a cohort and observe them for 6 months to see if they develop cancer. Now, an athletic population, it might be appropriate to observe them for 6 months. That might be the length of a season. But you've got to understand how long it might take a disease to develop. Another example would be, let's say you're working with an occupational group. So maybe migrant farm workers at a vineyard or people working at a construction site. You wouldn't observe them for just 1 month to see the incidence of injury that occurs. You would need to follow them for a significant period of time. How long do you know? Well, maybe there's some information already presented in the literature that could help guide that. Maybe you could talk to HR and find out about annual injuries, annual numbers of kind of work comp claims. But that's a really important point, that number 2 there, meaningful period of time. And then finally, all members of a cohort should be observed over the full period of follow-up, or methods should be used to account for dropouts. So again, the prospective cohort study, this is the gold standard. You've got a group of people assembled at one period of time, and then you are able to dichotomize them into a exposed or the at-risk group and the unexposed or the reference group. Again, everybody is disease-free at baseline. This provides incidence data. And again, another name for a cohort study is an incidence study. You're able to assess the relative risk accurately. This is the best estimate of risk. Usually, a large population needs to be followed for a significant period of time, often several years. Usually, more common diseases or disorders are assessed. Here's that picture again, looking at baseline in the present, the population without the disease, and then you dichotomize them into one of two groups and follow them into the future. Here again is that basketball example that we looked at in week number 3. As you take a look at this here, does this make sense? Can you imagine within your disciplines, your areas of practice, what population could be disease-free, injury-free at baseline? Now, I will put one asterisk in there because let's say you could do a prospective cohort study, and let's say you've got 200 people that require a surgery for a particular condition. 100 people get one type of surgery, 100 people get another type of surgery. You could follow them forward in time to see what the risk of recurrence is. You could see about the risk of graft failure. You could see about risks of a variety of things. You could also take a look at what the outcomes are. Right? You could be 4 times more likely to have a good outcome with surgery A versus surgery B. So the classic cohort example, the Framingham study, they followed more than 5,000 people. It's a lot more than that. This comes from the textbook, but it's way more than that now. And they've identified several factors that are associated with developing coronary artery disease. Prospective cohorts, people assembled in the present and followed into the future. And again, what is the counter to that? The retrospective cohort. This is where you identify past records and then follow forward up to the present time to take a look at differences between groups to account for risk. Studies that utilize large data sets from computerized medical databases really help to allow somebody to do a retrospective cohort study. Again, remember, retrospective cohort studies are historical or retrospective in nature, similar to a case control study, but it is not the same as the case control study. Again, major advantages of the retrospective cohort is that they take less time, they're less expensive, and much easier to perform. Again, the disadvantages are you cannot undertake a study of factors not recorded in the database, and there's the possibility of bias if data was not collected in a standardized manner. Here is that layout again. If you look at it, it looks kind of like the prospective cohort study, but you've got to look at where number 1 is. Number 1 over here in the right lower corner, that is the present. And in the present, you have no idea the proportions per group. That's where you have to go back to the past when the group was first assembled and then come back to the present time to see the proportions. Here again is that example of the women who had been admitted to the skilled nursing facility and they had no history of falls, but then you notice a lot of falls were occurring. So in the present, you would know that you've had 70 falls out of 200 people, a very, very high number. You want to go back in time when they were first assembled and look at the data that you collected at baseline. What was that admission data like? What was those initial rehab intakes like when you did the initial physical therapy or occupational therapy examinations? Here's an example of a retrospective cohort study. Why would you say it's a retrospective cohort study? Well, for one, oftentimes the authors put it in the title. And so imagine what this would look like here. Epidemiology of bone stress injuries in Australian high-performance athletes. So maybe what they found is after a while, individuals were developing bone stress injuries. And so what they did is they then went back in time to take a look at some measure. And what did they do here? So methods, a retrospective analysis of clinical records contained within the Australian Institute of Sport Athlete Management System electronic database. So there you go again. There is that example on how, if you have access to those databases, you can play in that database sandbox and explore a lot of things. And so they looked at a variety of things that you can see there: athlete age, sex, activity, etc., etc. And they found that double the cases were recorded in female athletes. So then you would start to wonder, okay, well, what could it be about the female athlete that is putting them at a greater risk? And of course, here is some information, again, kind of from the methods section. One thing I want to highlight here, the strengthening the reporting of observational studies in epidemiology strobe statement. So if you were to go into doing epidemiologic research in the future, you may need to check out the strobe and whatever is required with the strobe, complete that, whether it's registering it or just completing a checklist. More and more journals are asking for that type of stuff. Here was a retrospective cohort example. This one was a very influential study in the early 2000s. And what it was published in the North American Journal of Sports Physical Therapy, which later became the International Journal of Sports Physical Therapy. And what they looked at was the functional movement screen. For those of you who aren't familiar with it, it was something developed by a physical therapist. It's 7 different tests, functional movements. They're scored 0 to 3. And what they found were that pro football players that had a particular score, I think it was below a 14, were 11 times more likely to get injured, have a significant time loss injury that put them on the disabled list. So you probably have heard that term before in professional football. This athlete's on the disabled list at this time. And 2 important things about this study. One, their operational definition of an injury. It's always important to remember the operational definition of an injury. They had an operational definition of an injury that somebody had to have an injury that caused 3 or more weeks of time lost from sport. So that shows a level of severity, right? And then they allowed any mechanism of injury. So it could have been contact or non-contact. Think about professional football. A lot of contact injuries, right? It is just violence is part of the sport. Violence in the aspect of high collision activity. Well, a lot of people then tried to replicate this study with a variety of different populations, and they could not validate the findings. So why do you think that is? Well, one, this study allowed contact injuries. If your follow-up study doesn't include contact injuries, you're not going to find the same results. And if you have a definition of injury that isn't as specific as theirs, you might not have the same results. So this was a very popular study. It really helped to popularize even more so the functional movement screen within physical therapy, within athletic training. But, and this is I think the important teaching point, is many times when an initial risk study comes out, it may not hold up in a subsequent study. Case control studies, again, these are historical in nature, but the difference between these and the retrospective cohort is you're comparing cases and controls and going back in time and asking people about potential exposures. I like this graphic here because it's comparing prospective control or prospective cohort and clinical trials. Both of these, one's observational, one's experimental, both can compare disease incidence. Both are moving into the future. I also like the way to think about prospective cohort studies, that P equals planned. It's planned, whereas a lot of times the retrospective cohort studies aren't planned. Retrospective cohort studies go back in time, look at what information was available, then come back to the future. And then case control studies, again, as we saw there, we look at cases, we look at controls, and then we go back and compare potential exposures. Different ways to express and compare risk. Absolute risk, this is the probability of an event in a population under study. Value is the same as incidence. So absolute risk, the number of new cases over a period of time divided by the number of people in a group. For example, absolute risk, the death rate, the absolute risk, lung cancer in smokers, 341.3 per 100,000 years, or 3 to 4 per 1,000 years. You can compare death rates in lung cancer in smokers to lung cancer in non-smokers. And so this particular slide shows that absolute risk number. You can see that it's much higher, obviously, in the smoking population. The attributable risk, this is the additional risk of disease following exposure over and above that experienced by people who are not exposed. The answer is expressed as the attributable risk, the absolute risk of the disease in the exposed persons minus the absolute risk in the non-exposed. So if we look at the smoking example again, basically it's doing some subtraction. The attributable risk is 326.6 per 100,000 years. The attributable risk is known as the risk difference. Relative risk, this is an important statistic. This is how many times more likely are exposed persons to get the disease relative to non-exposed persons. Relative risk, also known as the risk ratio. This is the statistic that should be used in prospective cohort studies, also could be used in retrospective cohort studies. Here is the way we could do the math, 2x2 table. Now, a lot easier to do things using OpenEpi or using something like SPSS. But if you wanted to do the math, this is the way you would do it. So here's the relative risk, again, used in cohort studies. Relative risk, you can see the math there. Now, what's important with relative risk is understanding what the numbers mean. If you get a relative risk that's greater than 1.0 and it is statistically significant, that means there is an increased risk in the at-risk or exposed group. So when you see something that is 1.5 times more likely, a relative risk of 1.5, you would say the at-risk group was 1.5 times more likely to experience the disease or sustain an injury. On the flip side, if you were to run the stats and you get a number that is less than 1.0, and if it was statistically significant, you would say, oh, in actuality, the at-risk group was at a lesser risk. They actually experienced a protective effect. So you just hypothesized incorrectly. Now, if the number is 1.0 exactly, then that means both groups are or have a similar risk, that there's no difference between the groups. So here's doing the math. Here's an example looking at the risk of sudden death, comparing those who do excessive exercise versus those who do moderate exercise. Calculating the relative risk there, running through the numbers, we see that excessive exercisers are 6.7 times more likely to incur sudden death than moderate exercisers. Now, see how the table's laid out. This is important because whether you do it by hand or whether you enter it into a software like OpenEpi, you need to understand that the top row is the group that you think is at a greater risk. The bottom row is the group that you're hypothesizing to be at a lesser risk. The column on the left should be the disease or the injury group. and the other one being individuals who did not experience the disease or the injury. Now, you can also do relative risk using incidence density data. And so here's an example where we have the number of individuals that have experienced sudden death in each group and the total number of person years. So how do we calculate the relative risk? Well, we want to divide the injury rate per person year. So to do that, we would take, for the excessive exercisers, 16 divided by the person years, and then multiply that by 1,000 to get 6.8. Do the same thing for the moderate exercisers, and then divide one from the other. And with this one here, we get a relative risk of 7.6 times more likely to develop or to have a sudden death versus moderate exercisers. Population risk, how much does a risk factor contribute to the overall rates of disease in groups of people rather than individuals? This is important for determining risk factors and identifying which are trivial for the overall health of a population. There's the population attributable fraction. Fraction of disease occurrence in a population associated with a particular risk factor. This is calculated by doing the population attributable risk divided by the total incidence of disease in the population. For the majority of things we do, we aren't going to be involved with doing population risk stuff. Again, that would be probably if you're getting into more public health. For those of us in rehabilitation, in nutrition, in medicine even, again, there's going to be probably, we're focusing on things like relative risk and the odds ratio as well as the rate ratio. Taking other variables into account, many other variables are involved beyond just exposure and disease. Other variables can cause unwanted artificial change in the observed relationship between exposure and disease. That's that confounding, leading to incorrect conclusions about the relationship. They can modify the magnitude of the exposure-disease relationship. Extraneous variables are variables that are part of a system being studied but are not the exposure and disease of primary interest. Study of exercise and sudden death, extraneous variables might be age, right? Maybe sudden death might be more likely in 50 and 60-year-olds than in 20-year-olds. Or other things like BMI, coexisting diseases, cardiovascular disease risk factors. Another term for extraneous variables are covariates. Something we'll touch on in the next lecture when we look at case control are odds ratios. Odds ratios, you'll sometimes see people use these in cohort studies, probably not the best because it may inflate the risk. For example, I published a study one time that the relative risk for injury was 4 times greater in volleyball athletes, but if I would have used an odds ratio, it would have been 11 times greater. Does that sound bigger, more meaningful? Yes, but you can overinflate. Odds ratios are important for case control studies, but if you do any type of regression, if you do any type of adjustment measures to account for other variables, then you would want to have an adjusted odds ratio. Crude odds ratio is just the straight, it's kind of equivalent or similar to the relative risk. And again, we'll see that in the next lecture. Do want to highlight that a Rocky Mountain University graduate early on in the history of Rocky Mountain University, his name was Phil Plisky. He got his Doctor of Science from Rocky Mountain University. Before the PhD program was in place, Rocky Mountain had transitional DPTs, transitional OTDs, and they had several different Doctor of Science degree offerings. And then those evolved into PhDs. But what Phil did was he did an epidemiologic study looking at injury based upon star excursion balance test performance. And the whole purpose of this particular slide is to show that in his study, even though it was prospective in nature, he didn't use the relative risk. His team, they used the crude odds ratio to look at risk based upon different characteristics, different variables. And then they used an adjusted odds ratio to account for those other potential variables that needed to be considered. So again, this is just showing that how that might be presented in a paper. All right, this is the end of lecture 4.1. When you're ready, move on to 4.2.